Speaker, Dr. Jayshree Sood.
I welcome Dr. Jayshree Sood. She is the chairperson, Department of Anesthesiology, Pain and Perioperative Medicine, and is working at Sri Gangaram Hospital, New Delhi. She has held important positions. She has been MDA and DA examiner in several universities and DNB examiner for National Board of Examinations. She is also a member editorial board of Indian Journal of Anesthesiology and past president, Indian Society of Anesthesiologists, ISA Delhi branch, and Indian Society of Study for Pain, ISSP Delhi branch. She is also founder member and trustee, Indian College of Anesthesiologists, and she has been been awarded the Best Academician Award 2011 from Sir Gangaram Hospital, New Delhi, and she is the editor of Anesthesia and Laparoscopic Surgery 2007. She has also edited Atlas on Procedure in Neonate and Pediatric Practice 2012, and her areas of interest are pain therapy and anesthesia for laparoscopic. She's a very good anesthetist, and who can tell better than a person who has already taken anesthesia from her, like me.
Thank you very much for the kind words of introduction. At the outset, I would like to thank the organizers for having invited me here today to deliver this talk on newer drugs. Do we have the best in ambulatory anesthesia? The next two topics are also falling in ambulatory anesthesia, so I will be touching mainly on the newer aspects as has been asked by the organizers. I bring greetings from my hospital. This is the Sir Gangaram Hospital, a 650-bedded super specialty hospital situated in the heart of New Delhi. We have a dedicated daycare center, and we do almost 55% of our surgeries as daycare, and daily we do approximately 100 surgeries. Any anesthetic procedure requires a smooth induction, maintenance and recovery. However, for ambulatory anesthesia, the patient should be discharged within 23 hours of hospital stay, after having met the discharge criteria. The usual reasons for delay are pain, nausea and vomiting, which we have to take care of. Of course, the surgical conditions like retention of urine and bleeding are the surgical causes. Definitely, newer drugs, newer anesthetic techniques have popularized ambulatory surgery, but do we really have the best? So we'll just go through the armamentarium that is available to us. Anesthesia for ambulatory surgery, of course, can be done under local monitored anesthesia care, regional and general anesthesia. Let's see the first aspect. Any procedure, especially done under local, would require sedation. And in this we have still the benzodiazepines, in which midazolam is very popular. It does produce anxiolysis, sedation and amnesia, and produces what is known as conscious sedation. And given intermittent boluses of 1 milligram, a procedure under local anesthesia can be done adequately. Orally, it is very popular as a pre-medicant, especially for the children, if given about half an hour before surgery, because of its good absorption. But it produces prolonged recovery, there is respiratory depression, and if given along with opioids, it can produce cardiorespiratory depression as well. What about the procedural sedation being done under total intravenous anesthesia? Here we have had propofol for several years. It has a favorable pharmacokinetic and pharmacodynamic properties. It has rapid onset, rapid duration. It's non-cumulative. It has a very short context-sensitive half-life and an inherent anti-emetic property, which has made it a very popular drug for ambulatory anesthesia, especially even used as a total intravenous technique. But again, we know it is not an analgesic. It produces pain on injection. Whatever methods we use to try and avoid it, very often the patient still has pain. It does produce hypotension and has to be given very carefully, may produce airway obstruction, and has a narrow therapeutic range. In this regard, we do have phos-propofol, which is a newer water-soluble phosphate prodrug of propofol, which is converted to propofol within minutes of intravenous injection. There is no pain on injection, there is no hyperlipidemia, and there is no risk of infection. But this too, because it's a prodrug, it has a slow onset and slow offset, and therefore it is used for moderate sedation. And it too has a dose-dependent respiratory depression, hypotension, and apnea. But we know that these procedures cannot be done only under sedation, and analgesia has to be supplemented. I would like to add here about ketamine, although it has been used for ages. Why I've added it here is because of its resurgence in ambulatory anesthesia in very small doses. We know it's an NMDA receptor blocker, and in low doses of 0.1 to 0.2 milligram per kilogram has actually been seen to reduce the dose of propofol for sedation, not producing any respiratory depression, and it has a significant opioid sparing effect. And this is probably because the synergism is because the opioids act at presynaptic, whereas ketamine is acting at the NADM receptor, which is postsynaptic. Ketofol, which is a combination of ketamine and propofol in both in infusion forms, is being used successfully for ambulatory procedures. Non-steroidal anti-inflammatories, again, we are all very well aware. We started off with the simple COX inhibitors, where the analgesia was without the sedative effects of opioids, but it has gastric irritation, renal insufficiency, bleeding disorders, hepatic dysfunction, and allergic reactions. So came the COX-2 inhibitors, in which we have the celecoxib and the rofecoxib. Intravenous preparations of pericoxib are also available. But again, the kidney problems are here and therefore do not have the ideal conditions. Fentanyl is very popular as an opioid for ambulatory surgery. It is very potent, but remember it has a slow onset. The peak effect comes in about 4 minutes, but it does have a cumulative potential. Remifentanil, which is soon going to be available here, it's a potent synthetic opioid, 20 times more potent than alfentanil. It has a very high therapeutic index, rapid onset of analgesia within 1.5 minutes. It is rapidly metabolized, it is hydrolyzed by the ester linkage, and the total clearance is unaffected by the duration of infusion. It's non-cumulative, and the elimination half-life is just about 8 to 10 minutes. The context-sensitive half-life is also very low, about 3 to 5 minutes, and there's a rapid and predictable emergence. So it has been used very successfully for conscious sedation. But here again, in higher doses, being an opioid, we get post-operative nausea, vomiting, hypoxia, respiratory depression. Now, since there is absent residual opioid effect because it has such a short context-sensitive half-life, adjunctive analgesia is very absolutely necessary for post-op analgesia. Actually, it is said that if you are using remifentanil infusion for ambulatory procedure, you must at the same time start some other medicine so that the post-op analgesia takes over. Now coming to acetaminophen, which is of course has come into India and has become very, very popular. This is a synthetic non-opioid, centrally acting COX-3 inhibitor. It inhibits prostaglandin synthesis, has opioid sparing activities, and is in fact the safest, one of the safest analgesic and antipyretics available with a high therapeutic ratio. It doesn't affect platelet function, it has no peripheral anti-inflammatory action, no gastric irritation, and no clotting abnormalities. It is metabolized in the liver by glucuronidation, sulfation, and oxidation. And it is very popularly used as an adjunctive therapy as a part of the multimodal analgesic management. Given intravenously, it produces a high and rapid plasma concentration, and the effect comes within 5 minutes of administration. We know the dose is 1 gram over 15 minutes every 6 hours, and the daily maximum is 4 grams. Given as a suppository, it is the best route of administration because the ones that are given orally may be associated with the child may actually vomit it out. So this is the best route, and it produces high blood concentrations and lowers the pain scores. And this is the loading dose that is being given. But here again, there are a few complications that have been reported. If given in a single dose more than 15 grams, hepatic necrosis may result. And in patients with G6PD deficiency, you might have methemoglobinemia and hemolytic anemia. Tapentadol, which has come recently, it is a centrally acting analgesic. It has two mechanisms of action, a mu opioid agonism as well as a norepinephrine reuptake inhibition. It's a non-racemic compound, it has no active metabolites, and it is as effective as morphine, with a lower incidence of nausea and gastrointestinal adverse effects, as well as a lower incidence of respiratory depression. Probably it is said the addition of tapentadol to our armamentarium may improve post-op analgesia after ambulatory surgery. It is available in several tablet forms, but it has its several contraindications. It is contraindicated in patients with bronchial asthma, known paralytic ileus, and if the patient has been recently on MAO inhibitors. We've talked about sedation, we've talked about analgesia separately, but as somebody was just talking about, dexmedetomidine combines both sedation and analgesia, and is again a very good drug that has been introduced. It is a highly selective alpha-2 adrenoceptor agonist with an alpha-2 as compared to alpha-1 ratio approximately 1600:1, produces both sedation and anxiolysis rather than hemodynamic actions. It has a minimum effect on ventilation, and it maintains the normal ventilatory response to hypercarbia, so probably is safe in morbidly obese patients as well. It has a slow onset of action and a long duration of action. It has been used successfully for procedural sedation in bolus doses or as a continuous infusion. And even in pediatric procedures where you're doing MRI as daycare, it has a very good buccal as well as nasal absorption. But it produces hypotension and bradycardia, which has to be definitely remembered and taken into account. A combination of dexmedetomidine and ketamine has been reported, that you give initially a bolus of the two, followed by infusion of dexmedetomidine and ketamine, and it has seen that it speeds up sedation and probably prevents the bradycardia and hypotension, which is seen with dexmedetomidine alone. Also in intravenous regional anesthesia, it has been reported that if you add 0.5 mics of dexmedetomidine as an adjuvant to the local anesthetic, it produces a longer period of subjective comfort, it improves the conduct of regional anesthesia, and as well as improves the regression of sensory and motor block, improves the peri and post-operative analgesia with no significant sedation. Intrathecally also it has been given, and it produces antinociception and sedation. So dexmedetomidine, although has been very, very good, but it has its own problems of hypotension and bradycardia. After having considered the sedatives and the analgesics, coming to the local anesthetics, we know about the bupivacaine, which is being used all the time, but in the addition now we have the ropivacaine, which is nothing but the propyl group which is added on the piperidine chain. Coming to ropivacaine, which is a new amino-amide local anesthetic, it's basically a pure S-enantiomer of the propyl derivative. It is less fat soluble, preservative free. It has a similar pattern of sensory block, less motor block, and since it depresses the Vmax lesser than bupivacaine, there is less prolongation of PR interval as well as the less prolongation of the QRS complex. Therefore, if accidentally injected intravenously, it is less cardiotoxic. It is available as 0.2, 0.5 we know, maximum dose is the same, but the convulsant properties are the same as bupivacaine. So although the cardiovascular arrest, convulsant are the same, there is prolonged analgesia, and if given in intravenous regional anesthesia, it gives us a 20-minute window period of analgesia after tourniquet release, which is not there with lignocaine. Levobupivacaine, which is a pure S enantiomer of bupivacaine. It has a safer pharmacological profile, less depressant on the myocardium as well as the CNS, and it has a superior pharmacokinetic profile. Why it is less toxic? Because it is increased protein binding is there, therefore the unbound fraction is less. Similarly, there is higher clearance of this unbound drug, so a shorter elimination half-life. And because post-operatively there are increased levels of alpha-1 glycoprotein, the bound levobupivacaine actually falls and there is less toxicity. It has been seen when used in ambulatory surgery, there is rapid regression of motor block. So also if it given subarachnoid in a small dose, there is early discharge after ambulatory surgery. What about general anesthesia? Both sevoflurane and desflurane are being used very successfully. Sevoflurane we know has remained as the induction agent of choice for inhalation induction in the pediatric, in any population, especially the pediatric population, and maintenance of anesthesia has been recommended by desflurane because it has been said that there is a slightly faster time to awakening. Although between the two, sevo and des, the home readiness actually is equal. But both these drugs are associated with emergence phenomena, although they may be less so with desflurane, but they are still being reported. Muscle relaxants, if the daycare procedure is being done under general anesthesia and a short-acting relaxant is to be given, cis-atrachlorium is advisable because it is 4 times as potent as atra, but it is metabolized by Hoffman elimination and does not release histamine. Why I've added Sugamadex in this lecture is, of course, if the relaxants are being given, Sugamadex must be included because in case the procedure is very short and has to be reversed, this is the drug that is going to be available very soon. This is a modified gamma cyclodextrine. It is a selective relaxant binding agent forming very tight water-soluble complexes, and this is especially effective against rocuronium, as we know, maximum against rocuronium, then lesser so with vecuronium and pancuronium. But this has its own side effects of hypotension, nausea and vomiting. What about post-operative nausea vomiting? We have a full lecture following this. However, among the newer drugs that are available, here remember it is a multimodal technique that has been mentioned and has always been recommended. And among the newer ones that are available, we have the serotonin receptor antagonist. Again here ondansetron is of course being used regularly, but granisetron and dolasetron have come recently, as well as pelanosetron. The advantage of these serotonin receptors is that there is a linear dose response curve. That is, increasing doses achieve a greater clinical effect unless the maximum effective dose has been reached. This is their advantage, and these are the several doses that have been given. The duration of action is as long as 24 to 72 hours. But side effects like headache, dizziness and constipation have been reported. Pelanosetron, which is recently available and will be also there in the intravenous form, it has got unique pharmacokinetic properties. That is, after an initial decline in plasma levels, slow elimination takes place and a single daily dose is recommended, and this is the enzyme pathway by which it is metabolized. What about cholinergic antagonists? Transdermal scopolamine patches are good to prevent post-operative nausea vomiting, but they are associated with a dry mouth, and they are recommended as an adjunct with ondansetron for preventing PONV. Neurokinin 1 receptor antagonists are also there, and all these drugs, as we all know, are basically been introduced to prevent the nausea and vomiting associated with chemotherapy. And these are the drugs aprepitant, rolapitant, and they have been recommended for, of course, the chemotherapy, that they have to be given 20 to 30 minutes prior, either intravenously or if it is given orally an hour before. It completely inhibits the binding of substance P, which is a neuropeptide released from enterochromaffin cells. So, After having reviewing all the newer drugs that are available, do we have the best in ambulatory anesthesia? As we can see, no single intervention is completely effective. And even now for analgesia as well as for preventing PONV, we say a multimodal team approach. This is still there in the guidelines and in all the books that it is a multimodal, meaning thereby no single drug is effective. So, is there anything that is coming up in the future? Yes, for a benzodiazepine, we need a short-acting benzodiazepine agonist, which should be faster onset than midazolam. And this is this molecule, the new esterase hydrolyzed benzodiazepine, which has a rapid onset, short duration, and a fast recovery profile, and is probably being recommended for short diagnostic procedures. So also this is another molecule which is a novel isoindoline derivative which acts exactly at the benzodiazepine receptor site. It is chemically different from benzodiazepine but a fully agonist at the receptor and fully reversible by flumazenil. So probably in the coming years we will be having these new drugs to our armamentarium and probably better for anxiolysis to be given preoperatively. What about analgesia? Yes, we need drugs which are more specific on the mu receptors and more non-opioids coming in the picture. And besides newer drugs, probably newer routes of administration. Of course, we know transmucosal and transnasal are available for certain drugs, but probably newer routes for other drugs should also be available, which might help us in providing ambulatory anesthesia. So to conclude, yes, newer drugs have definitely improved our ambulatory anesthesia status, and the patients are going very happy as desired. However, we are still not the best and we still need many more to come. Thank you.
Thank you, Dr. Sood. Any questions from the House?
Good morning, Madam. I am Anand Isarka from Gondia. Regarding this dexmedetomidine, it was mentioned about the buccal and nasal route of administration. Can you please tell something more about the dose and the formulation? Is it drops or?
No, it is the same drug. The formulation has still, as such, that one has not come, and it is really not yet approved by the India standards. FDA is approved, and it's the same drug that we are using that is coming in the ampules.
The same thing?
Yeah,
are you using it buccally and nasally?
Yeah.
So how much
Just
dose is to be given and how much prior
it's
to
the same. What? Sorry.
What is the dose for buccal and nasal administration?
Same 1 mic per kg.
Okay, and approximately 20 minutes prior, same as intravenous route?
Yes. Okay. Just the same way as midazolam is a little bitter, but we use it just the same way.
So the bioavailability of the drug is it same as IV?
It's better.
Is it better?
Yeah.
Right. And it is same effective potency, everything
Yes.
is same?
Yes.
Thank you. Another thing, madam. What is the intrathecal dose of dexmedetomidine and what is the duration of analgesia?
No, actually there are only few studies that have done that. Not all have supported it as most of the adjuncts have come. So these are a few reports in which they mention 0.5 microgram. But there are only a few studies. It has not been completely evaluated that it should be used.
Right. Of late I am using this preservative-free morphine intrathecally. And I am finding very excellent results post-operatively in terms of analgesia and patient's overall satisfaction. It gives intrathecal morphine.
Yeah, that's true.
But the only thing I am finding is about 10% incidence of intractable nausea and sometimes vomiting as well. So is there any good good drug to control this post-operative nausea, vomiting, intrathecally administered, opioid-induced?
Yeah, first of all, for ambulatory surgery, we would not really recommend this. This has been used for many years together, especially for major surgery. It is very, very popular. But for ambulatory, you would not unnecessarily like to do this when you have other adjuncts. And in case you do have, for this you should have a protocol. If you are giving a patient any kind of either subarachnoid or epidural opioid, then you should have your protocol that is said that this patient has to have ondansetron regularly 4-hourly as a protocol. So we would normally not use it for daycare.
Right, okay. Yeah, that's fine. Thank you.
Thank you, ma'am.
Thank you.
I would now like to call the next speaker, Dr. Subhendu Sarkar.